Good morning, friends. And at the outset, I would like to thank eCancer and the organizers for giving me this opportunity. So, I have some considerations within my talk, and that is when I talk of stomach cancer and colon cancer, I mean adenocarcinoma. There are other pathological types as well. Strictly speaking, if I wear my gastroenterologist hat, early cancer is slightly different than what we have proposed to cover here. In stomach, early cancer means T1 tumors. They are early, even if the lymph node is positive. And in colons, they are T1 and T2. But essentially, they are early, so they can be endoscopically resected. But these are common. They constitute more than 50% of cancers in countries where the incidence rates are very high and routine screening procedures are carried out in asymptomatic populations. They are usually asymptomatic. In India, they constitute less than 10% of the cancer. So, as a result, I'm going to cover something that is, I wouldn't say early, the real early, but slightly later early cancers. So this is what has become the standard now. It developed in Far East, in Japan and Korea, and now endoscopic mucosal resection is what is it is called ESD for short, is what is large tumors which are mucosal in nature, which are early, can be resected. This is now accepted, and the expertise is growing in the West. How do I change this? And even in the West, the expertise to do ESD is very limited. So let us get on to management of early stomach cancers. If we look at the global stomach cancer problem, you will find that India has relatively low cancer rates, around 5 per 100,000, although there are parts of India that have very high rates. So in general, stomach cancer is a disease of Asia and Eurasia, and not so much in Europe and North America. So if we look at the Eastern guidelines, the Korean, for example, I've chosen. If you have an early cancer, which is less than 2 centimeters in size, there is no ulceration, and it is a well-differentiated cancer, you can do endoscopic submucosal resection, and then based on the pathology, observe the patient or subject the patient to surgery. And if the tumor is bigger than 2 centimeters in size, or it is poorly differentiated, or it is ulcerated, then the approach is slightly different. In expert centers, they may still attempt ESD, but it is a weakly recommended statement even in a country like Korea. And please remember that this is a recommendation from a country where screening is routinely performed for detection of early gastric cancers, and they have very high expertise in doing ESDs. For slightly more advanced early gastric cancers, that is tumors involving beyond the submucosa, and stage 2 and 3, they have slightly different approach, and that is to do a upfront surgery, which will almost always be a D2 lymphadenectomy, which requires expertise, and that involves clearing lymph nodes along the vascular pedicles, and this may be done as an open surgery or as a laparoscopic surgery. But in Europe and Western guidelines, and I've chosen the ESMO guidelines, you can see for very early gastric cancer, the treatment is the same. You do ESD, and then based on the findings, follow up. But for anything more than that, the preferable pathway is to give perioperative chemotherapy followed by surgery, and followed by postoperative chemotherapy. For a smaller group of patients, you can do upfront surgery followed by adjuvant chemotherapy or adjuvant chemoradiotherapy. And this is practiced in countries where there is no screening for gastric cancer, and therefore vast majority of the patients are diagnosed with more advanced forms of cancers. So if you were to look at these two scenarios, then what do we recommend choosing wisely for the real early ones? Do not use routine screening in India because our gastric cancer rates are low. Maybe the only state where probably one could do is Mizoram, where gastric cancer rates are around 35 per 100,000. But in all other states, it is less than 10, less than 5. And most people who will be screened, you will find other things, but you will not find a gastric cancer. Second is, if at all one is going to perform as not a screening but a surveillance endoscopy, it should be done properly and not like doing 100 endoscopies in one endoscopy room from morning till night, as it happens in all our leading medical colleges. You can't see anything. I have seen how screening endoscopy is done in Japan. It takes 30 minutes. It needs washing out of the entire stomach, photographing every nook and corner, and that is the way it is done. If that we can't do, we shouldn't be doing it. There is no need to over-investigate patients who have been found to have very early gastric cancers, because you may end up finding incidentalomas and then start chasing them and ruin the life and the finances of the patient and the family. Do not try to do EMRs and multiple biopsies when ESD is the standard. In other words, there are less experienced endoscopists who will try to remove these tumors and leave behind tumors, mess it up, and make the further treatment more difficult. So if there is a potentially resectable early cancer, it should be referred to a center where ESDs are performed. There is expertise. It is like in sports, cricket. It's like America trying to play cricket. They are learning it. So it takes time. Maybe after 20 years, when they have learned it well, they will beat India, but not before that. So it's the same thing. ESD is a new game, and one needs to learn it properly. Then only one can do well. What about the less early gastric cancers? All patients should be brought to the MDT. Do not order PET scans unnecessarily. There are lots of false positives, particularly mediastinal findings are so common in our patients, and we sometimes chase them. I would like to recommend the European guidelines for our patients, because most of them are stage 3 or advanced stage 2. So use perioperative. We have used FLOT and MAGIC regimens, which are well tolerated by our patients. And always aim for a D2 resection, which means proper lymph nodal clearance and R0 margins, so that the patient doesn't end up with R plus resections and early failures. For patients who need upfront surgery, like the one who is bleeding or obstructed, or somebody with comorbidity where they may not be able to go through the whole peri-op and surgery, one can follow upfront surgery followed by the adjuvant therapy that is recommended in the Korean guidelines. What about the colorectal cancers? We have fairly low incidence of colorectal cancers, but colorectal cancer is common in Asia as well as in North America and Europe. So here I've used the template of the ESMO flowchart. If you have a stage 0, which essentially is a large polyp, one can do endoscopic removal and then follow up the patients. If it is stage 1, after either endoscopic or surgical resection, the patient can be followed up. Stage 2, you have to categorize them into low risk and high risk, and the low risk does not need any post-operative adjuvant therapy. The high risk can be given post-operative adjuvant therapy based on the risk status. And stage 3, in the new era, which I'm sure will be covered by the next speaker, will be classified as low risk and high risk stage 3 cancers. In the low risk, one can give 3 months of adjuvant therapy, and in the high risk, 6 months of therapy. For rectal cancers, things are slightly different because the failure rates patterns are different. It tends to have local failure rates. It has a tendency to have lung metastasis. So the rectal cancer is managed slightly different. the ESMO recommends dividing them into 3 groups. The very early lesions, which are the real early rectal cancers, one can do local therapies, endoscopic removal, transanal surgery, and then depending on the pathology, manage the patient appropriately. For patients who refuse such treatments or those who are unfit, because very often it can happen in very elderly patients, one can do something like local radiotherapy. For the early lesions, which are more than what can be removed endoscopically, one needs to do an MRI to do the staging, and if it is really early, the margins are likely to be free, one can go ahead and do the surgery up front. And for those who form the intermediate group, that means the MRI shows that the margins are threatened or there are lymph nodes, one would like to offer neoadjuvant short course radiation or neoadjuvant chemoradiation. These are the standard. There are many trials going on. I wouldn't go into those things. Please remember that adjuvant therapy given even with a simple drug like capecitabine can produce severe toxicity. Look at this lady at the end of 5 cycles of just plain capecitabine. You can see the severe hand-foot syndrome which is there, and this is the complication rate from the IDEA paper in NEJM published recently. You can see the neuritis rates are very high, almost 80%. So patients are left with neuropathy and so many other complications. So even simple capecitabine based adjuvant therapy can produce severe problems. So we have to keep that in mind, and trying to minimize the use of adjuvant therapy and shorten the use of adjuvant therapy is important. So choosing wisely for very early colorectal cancers, don't do routine screening in our patients, but also at the same time, patients who have rectal bleeding, they should be investigated and not passed off as piles and put on some homeopathic or Ayurvedic therapy, because that's something that we see very often in our country. Do not over-investigate patients who have stage 0 and stage 1A colorectal cancers which have been endoscopically removed. Otherwise, polypectomy is done, there is a focus of cancer on the polyp, and then they are getting a PET scan done to see if there is any metastasis. Do not attempt EMR when ESD or surgery is appropriate. That means large lesions that are probably going deeper down into the submucosa. Do not give adjuvant therapy to patients who have stage 1 and stage 2 low risk colon cancers, and restrict adjuvant therapy to those who have high risk stage 2 and stage 3 cancers. Take a proper family history, and I will allude to this in the next presentation that we have. And do take all patients who have more advanced colorectal cancers into the MDT. For the less early colorectal cancers, do an MRI for all rectal cancers before undertaking surgery. Do not order a PET scan. Do not routinely order molecular testing unless you are suspecting a familial cancer. Do not routinely operate on rectal cancers without evaluation and preferably preoperative radiotherapy, depending on the margins. And do attempt total mesocolic and mesorectal excision with the harvesting of more than 12 lymph nodes. That is absolutely essential. Do not give 6 months of adjuvant therapy to patients who have low risk stage 3 cancers, and do follow-up tests depending which has already been covered to look for resectable metastasis. Thank you.